Yeah, at the outset, thanks Dr. Singh and the RSSDI for giving me this opportunity to be with you this late afternoon. And the topic given is therapeutic inertia. And thanks to Dr. Malpani, who has already covered about 1/3 of my talk with an excellent comparison of both GLP-1 receptor agonists and the SGLT2 inhibitors. Therapeutic inertia, although the concept is from 2004 onwards, although the UKPDS, with its tremendous outcome of the trial, that there is going to be some sort of a memory item, which we'll discuss it later on, had a tremendous importance, which was extrapolated from the DCCT trial and the UKPDS trial, although it came much earlier. But the concept of therapeutic inertia in a condition like diabetes, it is also now, of course, applied to heart disease and even dyslipidemia. But I think application is tremendously more involved in diabetes. So rather than showing how many millions of diabetics we have and all that stuff, I thought this probably the population of the diabetic place, which is every center in India, by the time I finish my lecture and Dr. Singh finishes this session by 6 o'clock, there will be quite a few more thousands added in India and tens of thousands added throughout the world to this list. So no need to tell you how many lakhs and how many millions. I think what is probably important, I don't know why it's not moving. We all can we just silence one of the can we just silence all the can we move all other
may I request everyone to please mute your mic?
Yeah, I'm just saying that.
Other than speaker, please. Thank you.
We all know that diabetes type 2 is a progressive disease. We have all expected this very famous incredible loop of insulin resistance with progressive beta cell failure. And this is the one that ultimately drives to the postprandial rise and the fasting rise and ultimately the overt full-blown diabetes. And we also know that around 50% of the beta cells are fired by the time you detect diabetes. Now, initially, there was a bit of a difference of opinion. Even up to 2019, ADA started wondering whether should we think of a clinical inertia, which is lack of adherence to the guidelines recommendations, and appropriate to do so, or should we think of therapeutic inertia, which is failure to advance therapy or de-intensify therapy when it is appropriate to do so. But however, as of 2021, which in fact began last year, this is the classical definition now, but which has been subjected to comments as we go later on into the slides. Failure to initiate or intensify therapy when appropriate to do so, which means it concentrated on the therapeutic goal achievement. Now, this may not be all the time, because part of this was discussed by Dr. Malpani in his lecture. However, there was another class of thinkers who thought, okay, you are trying to intensify. What about some patients who does not need any escalation, or there is such a thing that you need to reduce the therapy, and they called this as therapeutic momentum or reverse clinical inertia. So I think this is extremely important. But with SGLT2 inhibitors, just now we thought there isn't anything like a reverse clinical inertia. So when we apply this applies to certain molecules, is what we are supposed to think. Now, this slide, whenever we see so many figures, we normally tend to foo-foo it. But if you just carefully see here, I have put Japan in red color. You can see that one of the richest countries, richer than America, has got definitely a many uncontrolled diabetes. Whereas if you come to US, I put it in green here, around 7.2%, despite them being generally obese, despite tremendous amount of junk food being eaten in US. All of us who have visited US, we know we get 3 times more the portion in any hotel than what we get in Indian hotels. And of course, when we come to India, we know we are in line with China, where almost around 9% HbA1c is very common. This is a landmark study, which I'm sure some of the people here have been involved in this trial. And Sattur Medical Care was one of the centers in the south. I'm sure many in this meeting also have been participating in this. Very good, large scale, longitudinal, observational real world. Very good study. You can see that 4 out of 5 diabetics are uncontrolled in India. Less than 1 in 4 Indians with established diabetes takes insulin. Average A1C at which insulin initiated is 9.2. The same thing, of course, is also being very well declared in Diabcare India 2011 study. Even in that time, one could see that is almost 2% higher than the ADA recommended target, the mean HbA1c, and this poor glycemic control, despite being on 93.2% of the patients on OADs and almost 35% being on insulin. Of course, this is one of the important slides. You can see that it is not US. On the extreme left corner, it is Germany. The doctor population ratio is excellent in Germany, not in US, and India, along with other third world countries, falling down where almost maybe around 10,000 people, and there is one doctor, and these doctors include the Ayush doctor, the homeopathic and other specialties, thanks to government of India, who want to make them surgeons in next couple of years of training. Maybe they may do lap surgery one day, end up with lap cholecystectomy doing them. So whether this decision is right or not, maybe this is not out of the purview of this lecture. The idea of this slide is that in India, each patient deserves around 2.3 minutes only. Maybe that the super specialists take a bit of more time. So in small words, the clinical inertia is multifactorial with a range of contributing factors. It involves the patients, the clinicians, and the healthcare delivery system. This is the UKPDS study that I was talking about, a landmark study ever. However, despite the microvascular downscaling, what happened and what came out extremely more effectively was in the 10-year follow-up, where the HbA1c sort of converged. Those who were on an intensive treatment had an excellent reduction even in the macrovascular, especially the myocardial infarction, by around 15%. And that came to be called as the legacy effect. And this legacy effect is not just on experimental module like UKPDS, that it is in the real world phenomenon, which is shown by the next two slides. This is again a study in the United Kingdom, a very good slide, one of my favorite slides. You can see here, this is a very large cohort of patients where follow-up was almost for 22 years. You can see here, if you lose the first year and go on to the second year and want to intensify in the second year, and you have allowed the HbA1c to stay more than 7, look at when you follow them at 5 years, the increased incidence of MI, the heart failure, and the composite cardiovascular events, meaning whatever we saw in UKPDS, the legacy effect, which is now in this case is dysglycemia, stays for a very longer period, resulting in a lot of cardiovascular ill effects. This is another study that we can just see. And in this also, where these patients were followed up for 10 years, we can just see that HbA1c of more than 6.5 for the first year after diagnosis was associated with a greater risk of future diabetic complications. When you compare them to HbA1c of less than 6.5 for the first year of diagnosis. However, when HbA1c levels were more than 7 for the first year after the diagnosis were associated with increased future mortality, increasing periods of exposure to HbA1c levels of more than 8 were associated with increased risk of microvascular and mortality, meaning legacy effect exists outside the trial population, which means in the real world, begins as early as the first year of diagnosis, making it almost implementary that we achieve near normal glycemia soon after patients are diagnosed with diabetes, which means the first year, the first 365 days, make certain that you don't give 3 monthly appointment like we normally do, but call them more frequently because first year is the most important year of their lifetime. So this is a real world scenario. This is what we expect, the expected trajectory in the experimental module, but this is a real life module. You can see the seesaw yo-yo movement here. This is all the variability in the HbA1c, and this dysglycemic legacy, as you see, would ultimately lead in congregation of both micro and macrovascular complications. Therefore, in people with type 2 diabetes, of course, to some extent, even in type 1, this is a challenge that just won't go away. Now, what could be the factors? It could be patient related for inertia, physician related, healthcare system related. I'll not go into the details, but just to make it important here that what happens to the patient barriers? You can see that the patient barriers of all important, although it falls fourth year, is hypoglycemia is the most important concern for any patient or even a doctor. Doctor is extremely rather edgy that he may get a night phone call when he has upped the dose of insulin for any of his patients who definitely had a raised creatinine and some amount of kidney disease. He's really worried through the night because of hypoglycemia. There is an unexpected response in all patients with CKD regarding any insulin upgradation. So then, of course, you have got too many medicines. You know that according to some studies, each diabetic patient should have around 7 to 8 drugs, a couple of drugs for hypertension, one drug for dyslipidemia, 2 to 3 drugs for diabetes. So that's what it is. Naturally increases the treatment cost. Poor communication with the physician will come to some other time. This is because of the lack of time, because volume game is excellent pastime in India. There are certain physicians who see patients till 1 a.m. We had one doctor in Hubli, not that I'm commenting negatively, who used to see patients till 2 a.m. Unfortunately, in the last 10 years, I'm glad with our junior colleagues, this style has gone, but this style has slightly shifted to super specialists. They go on till midnight now. That's what needs to be stopped. Despite that, there is a poor communication because number game is very important in India. So hypoglycemia is an important barrier. You can see all that here. Hypoglycemia is confirmed in a large number of type 1, type 2 diabetic patients. And as I already said, 74% of all these events occurred at night. Hypoglycemic episodes often go unrecognized. Those of us who are here and who do the continuous glucose monitoring are very well aware. In the morning, when you see them and analyze later on, you see that a blood glucose of around 45 milligrams, patient would not be aware that he had hypoglycemia through the night. So this is very common, and one of the worst consequences, we know that the pathophysiological cardiovascular consequences, I don't want to go into the detail, it could always exacerbate the inflammatory markers, and it could also try to exacerbate blood coagulation abnormalities like increased platelet activation. And in fact, there could also be endothelial dysfunction. And we know there could be sympathoadrenal response where there could be rhythm abnormalities, as we can see in some of the trials that we saw in type 2 diabetes. All in all, hypoglycemia definitely leads to increased mortality in these patients. This is again data taken from one of the Indian recent trials. You see that here, 2 in 5 patients reduce the dose on their own. They don't need us. 77% of the patients in India who experience hypoglycemia after 6 months of their insulin initiation discontinued within 1 year. I think this is very important take home point. This is again a very interesting slide. When you tell that there is a hypoglycemia, there are results for the GAP study. It shows that, okay, you tell us, it says, I would treat my patients more aggressively if there was no concern about hypoglycemia. You can see that here. Primary care physicians were only around 75. When this confidence was given, the specialists or the endos said 79% of them were ready to take the risk of hypoglycemia, meaning this study has been extremely well proven in Canada. In Canada, they did a study, compared physicians treating myocardial infarction. They compared the cardiologists treating myocardial infarction. At the end of the survey, it was found that cardiologists treating the myocardial infarction had a lesser mortality rate, lesser complications rate. I think this is a good slide in a way from this study that this is around 150 physicians, including endos. Endos are ready to take a bit of a more risk than physicians, which I think is very much understandable. Now, this is from my real patient. Okay, this is not just that doctors are always at a point where there is a therapeutic inertia. They fail to increase the therapy when goals are unmet, but it is a patient. This is a real patient. I had one lady who was around 55 years, coming from a very rich family, and she was on around almost maximum OHAs, around 3 drugs in 2018. SGLT2 wasn't very popular then. Her HbA1c was 8.2. I said, ma'am, I'm not happy. You have to go on insulin. She said, no, sir, please give time and I'll come in November. 2018 November, she came. It was 9%. She blamed Deepawali. Said, sir, we had guests and I ate sweets. Then I said, no, I can't let you. She said, sir, please give me 3 months. Then she came in Feb. And I asked her, this is 9.5. No way, I had to start you on insulin. She said, sir, it is Sankranti, it's a very famous festival in Maharashtra. I had gone to my mother's house. Then I said, okay. She disappeared, came in July with 9.7. And she said, sir, children have holidays. And in the month of June, we went towards north and had a good holiday. I said, it is impossible. I'm losing my patience. She disappeared and appeared the next November, Deepawali, when it was HbA1c of 10. So therapeutic inertia on the part of the patient, in India at least, is extremely important that we give real importance to this. Then, of course, the therapeutic barriers, we saw that the time constraints, and we saw that we aren't really updated. We are more reactive to patients than proactive. Some of the consultants towards end of the day lose their patience and try to shun off the patient. And of course, there are sometimes navigating guidelines. It may not be easy. The guideline may have been released, like discussed by Dr. Malpani. Even though HbA1c is normal, there is an indication that you could use the GLP-1 agonists or SGLT2 inhibitors in those patients who have an increased risk of ASCVD. So all these understandings are very important for a physician to understand. And also, of course, the side effects, very important. One has to really update himself with the side effect, because as we know, the fracture of the bones, including certain malignancies, like it was blamed in glitazones, although they are one of the best molecules. CA bladder, unfortunately in India, somebody created a noise saying it causes CA bladder, but ultimately it was not proven. And pioglitazone has come back with a vengeance, and glitazones are one of my favorite molecules. We'll discuss that in the discussion. So lack of clear guidance. There are many Indian guidelines, and RSSDI is one of them, and we really don't follow. We want to follow ADA, but it doesn't suit us. So these are all certain factors that we need to know. And of course, the healthcare system. We don't have a disease registry. We don't plan the visit. Sometimes we accept them anytime they come, especially in place like mine, Hubli in Karnataka. This is a 2-tier town, a famous 2-tier town. And I train around 40% of villagers. They come from around 150 kilometers to see me. And I can't say come with an appointment. So these are all the things. These are healthcare problems which do affect our ultimate therapeutic inertia. This is an extremely important survey done in Italy. 153 Italian diabetologists. And this is really taken as one of the important guidelines, even for ADA, in some of its references. Now, these 153 diabetologists were asked various questions. What in your mind would you think the impact of therapeutic inertia would have on certain complications. Now, what about the cardiovascular events? Now, that was rated highest. Glycemic control was rated lower. So this is how they tried to analyze all these diabetologies. Then they came on to see what about the healthcare professional related defensive medicine. Many of us practice defensive medicine and difficulty in managing complex therapeutic regimes. What to add when, like for example, EMPA can be used in the same dosage even till the last stage of the renal failure. While if you're using sitagliptin, you have to almost reduce it by around 75%. Now, unless you are updated, these are all complex therapeutic regimes and fear of side effects. Certain physicians, especially those who start in the beginning, initial phases of a physician's lifestyle, is going to make it very difficult. There is definite fear of side effects. Unfortunately, we had one physician colleague of mine who started practice with me and gave a shot of injection B complex. We know that B1 and B6 can cause really a lot of reactions, unlike B12. And the patient had a death outside his clinic. He has to close the clinic once and for all. So such sort of thing, very unfortunate. We use B complex many times as a placebo therapy for many patients, and we're always through. And one of the most successful practitioners is he who gets a hypoglycemia on the first day of his practice. Patient comes unconscious, you inject some glucose, he sits up and says thank you and runs out of your clinic. There can't be any better magic scene than that. I mean, these are all some of the effects that really put a lot of fear in these patients. Again, these are health system related. As I already said, no team approach. Many of the physicians refuse to refer to a cardiologist, especially in smaller towns. This happens very commonly. In big towns, he couldn't care less. The physician says, don't go. He's the first man to go and see. And even in two-tier town like Hubli, we have got around 20 cardiologists. We have got around 40 neurologists. So whether I want them to go or not, with my huge volume of diabetic patients, most of them enter their clinics. Of course, any chest pain now is a cardiologist. Any headache now is a neurologist. So these are all certain restrictions that we really need to see. And here, of course, we know that one of them needs more human resources, more trained human resources. We need to mitigate the therapeutic inertia, pressure on decision makers by the scientific society. We know there are so many scientific societies to come by. So these are all various points that we need to go. So ultimately, it decided that in Italy, they said patient education alone is critical. So they said, what causes the problem? The Paolo was the person who conducted this. So he said, clinical inertia drivers at all points, patient side, lack of education, and the physician side, lack of education, and the healthcare side, lack of education. What it needs is education, education, and education at all levels. This is an excellent slide, which is a representation, which is a cloud representation. The participants were asked to make 3 of their relatively frequent, what would call therapeutic inertia. And the bigger fonts are the ones which are mainly causing the therapeutic inertia. And you saw that, like in the previous slide, it is the education that the patients need, and it is the time that we physicians and the endos don't give to the patients. This is again one of the slides that although we have progressed in more number of molecules, achievement of the individualized targets, we know that diabetes is more a tailor-made treatment rather than a ready-made treatment. So you can see that there is a decline in the individualized targets over a very short span of around 8 to 10 years. The same thing happened. The percentage of HbA1c of more than 9 increased despite increased awareness, despite more knowledge about the drugs to be used. So what has gone wrong then? You could see that only about 50% of the patients reach the goal, and unacceptable levels of morbidity and mortality. All this despite more than 40 new diabetic treatment options approved since 2005. And very fortunately, from 2016 onwards in US and even in Japan, you have got combinations here. You can see that. Excellent combinations of degludec with liraglutide, glargine with lixisenatide. So we can see that that's only one such shot. Despite such advances, therapeutic inertia remains a major problem. So when we come to the goals of care, we want to prevent complications and we want to optimize quality of care. I don't want to go into this very busy slide. Just to try to see that, just look at the HbA1c, look at impact on weight, hypoglycemia, see, make a shared decision. I think word shared decision is going to be extremely important in future to come. And beyond glycemic level, we must think of atherosclerotic cardiovascular disease and the kidney disease that Dr. Malpani just talked off. And we have got also support the ongoing monitoring system, mainly with CGM. Now, also we have to think of cardiovascular inertia. You can see all this, what drives the clinical inertia in the management of cardiorenal risk, personal clinical experience. Although when it comes to evidence, this is dumped down as evidence E. But we know that in clinical practice, our own personal experience with agents that we are accustomed to makes a lot of difference. Like one of them suggested now that after 6 months, SGLT2 inhibitors do not suit some Indians because they are not generally obese. So such personal experience are probably important. Then obesity, as we just saw, limited knowledge of evidence from CVOTs and role of cardiorenal risk. So one has to really update himself, and lack of interdisciplinary, where we don't refer the patients to cardiologist or a neurologist or even to a dentist when gingivitis could be worsening the diabetes. These have already been dealt with, GLP-1 receptor agonists versus SGLT2 inhibitors. We can see the worldwide inertia to the use of cardiorenal protective SGLT2 inhibitors in high-risk patients with type 2 diabetes has already been excellently dealt with by Dr. Malpani. And even this slide has been shown. The idea of this slide is, apart from reaching the HbA1c target and get rid of therapeutic inertia, follow the intensification program properly, think of the ASCVD risk, think of heart failure risk, think of CKD risk, and use accordingly the drugs, being one of them, either SGLT2 inhibitors and GLP-1 receptor agonists. In my practice, it has not been the price of GLP-1 receptor agonists, it is the injectable form. So if they would always tell me, 9 out of 10 patients of mine would say, if I want to start them on, not the obese patients, on GLP-1 receptor agonists, which I rarely use in my practice, they would say you would rather start me on insulin and not on GLP-1 receptor agonists. So I'm one of the happy persons because oral semaglutide is coming. They cost around 60 rupees each unit. So probably it could be worthwhile in some of these patients. They have already been dealt with. And we know that we have to update ourselves because if we think of the REDUCE trial, there you can see that icosapentaethyl, 4 grams, has been suggested, which was a definite reduction around 30% in myocardial infarction. The idea of putting this slide is, it is not just the therapeutic inertia of the blood glucose. You have got to think of dyslipidemia and manage. And of course, we know that lifestyle behavior, exercise is extremely important. You don't exercise, consider it as therapeutic inertia. Indians have tremendous excuse. He keeps an alarm and puts it off. He says, I can't go, doctor, हमारे गली में कुत्ते बहुत हैं, तो मैं नहीं जा सकता. डॉक्टर साहब, मैं ऐसे गली में रहता हूँ जहाँ मुझे वॉकिंग के लिए मौका ही नहीं. We are full of excuses in our country, and exercise is rarely done here. And you know other things like weight loss, smoking suggestion, alcohol reduction, or recent studies have shown alcohol is not useful in Southeast Asians. It could worsen the outcomes in ASCVD, and of course stress management. And we know all this. I don't want to go into this. Many OADs are not going to be as effective as initiating and up titrating insulin when you tend to use. This is again a good thing here. One slide I want to emphasize. Suppose you tend to think of patients starting them on, say, an 18 units of insulin, okay? And maximum unit here, they say, is around 0.5 units, say, which is around 30 units, but you can go up to almost 60 units and more than that for basal insulin. The idea I'm trying to make here is, when you start the patient here on 18 units, you give him a 3 months appointment and you ask him, about 50% of our patients do not buy the glucometers. And even if they do glucometer glucose, even in our clinic, we ask them to ring our landline every fourth day. They don't ring. Some of them come at 3 months, and I go back to the booklet that we give them to enter the glucose values. They are 300, 280. I ask them, why you didn't inform us? They say, हम तो आ रहे थे, तो जब आते हैं तो बात करेंगे आपसे. So these are the things. So insulin initiation, optimization, intensification are all extremely important in our practice. So early initiation, we know that has recently gained tremendous importance, where you could give pancreatic beta cells a rest, and thereby probably they would require even lesser amount of drugs at a later date. And of course, artificial knowledge has recently been used. Continuous glucose monitoring, I find it extremely useful. Nowadays, even Panasonic or Medtronic, many units are available, cost around 5,000 to 6,000 rupees. And I think somewhere in one of these CME India, I read it costed around 10,000 rupees in your area. Unfortunately, our patients don't pay that much. I charge around 6,000 for continuous glucose monitoring. And I think it is extremely important to patients are so convinced and they look at their own graphs, we can get rid of therapeutic inertia. And of course, artificial intelligence, we know, has entered hypertension, diabetes, and heart failure management. So this is the summary key points. Clear communication, expectation settings, shared decision is extremely important. We have got to spend some time. Those who are endocrinologists could separate their diabetic clinics and not see the diabetics every day. Those who are physicians could also make a segment of their timing every day for the diabetic patients. So to end it all, if we want to get rid of the diabetic related therapeutic inertia, we must have a paradigm shift in our thinking.